So would it be important to know the management of aortic dissection depending on the type? So type A versus type B versus et cetera.
I think so, yeah, and I think that there are different classification systems for aortic
Yes.
dissections. Really, the one that I would hone in on is that Stanford classification system where you have the type A and the type B. And I do think that it is relevant to understand the differences between them, because maybe not so much for step one, very, very much so for step two, because it will inform your management of the aortic dissection going forward. So anytime you have any component of involvement of the ascending aorta, regardless of what's going on with the rest of the aorta, you automatically are type A. If you have no involvement of the ascending aorta, you can have descending aorta involvement all the way down to the bifurcation, frankly, you're type B. So it only the way you differentiate is strictly on the basis of what's going on in the ascending aorta. And the reason why we care is because a type A dissection especially is a surgical emergency, and there is a measurable increase in morbidity and mortality the longer you wait, the longer you delay surgical intervention. And so think about surgery for a type A dissection. The difference is really with type B. I think, I don't want to say more, I don't want to say absolutes, but oftentimes, and perhaps most of the time, you would more medically manage a type B dissection by bringing their blood pressure under better control, identifying and treating an underlying cause, which in the majority of cases would be hypertension for whatever reason. And so that is kind of the takeaway point in terms of thinking about management of aortic dissections. So anything to add about that? In terms
No,
of
yeah, I think you nailed it. I mean, the big thing is the ascending aorta is where all the complications are that we were talking about, right? So you can have the dissection into the subclavians, into the vertebrals, into the coronary arteries. That is life-threatening complications versus lower down, less so. And so really that's really the distinction point. And so they're not going to have a very subtle sort of distinction, but I think it is important to know sort of when you would do surgery, when surgery is indicated versus when it's not. And of course, if the patient is unstable, then that's a surefire way to say, yes, go to surgery. So.